Welcome back, everybody, and we hope everyone is prepared for another informative session. Without further ado, let's begin session 2 on respiratory. Please welcome our chairs, Dr. Anwar Khan, consultant neonatologist and head of department, NICU, Dubai Hospital, and associate professor of neonatology, DMCG, and Dr. Manzoor Ahmed, senior specialist pediatrician, neonatologist, adjunct clinical assistant professor, University Hospital Sharjah, UAE. Dr. Anwar and Dr. Manzoor, the stage is yours.
Good morning, everybody. I think it's time to come back to attend this topic today, the morning session of the continuation. And excuse me, may I have your attention, please? That's good. Today, we are continuing with this session. One of the hottest topic. Without this topic, probably the name would not be appropriate as the hottest topic of neonatology. That is BPD or bronchopulmonary dysplasia. And if I ask anyone, any of the neonatologists here, how to define BPD, I don't think we have a consensus. You will have different definitions you must be using in your unit. So that's why this is worth discussing and worth giving some importance on the talk on it. And to talk on this topic, I have the great pleasure and honor to invite Dr. Eric Jensen, who is an attending neonatologist in the Division of Neonatology in the Children's Hospital of Philadelphia, Nona Chop, Assistant Professor of Pediatrics, School of Medicine in the University of Pennsylvania. He got his MD from Washington University, Seattle, and he's a fellow in the neonatology in the CHOP, or Children's Hospital of Philadelphia. Dr. Eric, the floor is yours. Please come over and start your topic. I believe this will be very interesting. Dr. Eric, please.
Good morning. Good morning. Thank you for the opportunity to be here. It's a great honor to be able to present to this esteemed group, and I hope over the next 2 days to share ideas and to have dialogue related to BPD and all aspects of neonatal care. I have no disclosures. I'm honored to provide 2 presentations this morning. The first, as we've mentioned, will discuss evidence-based diagnosis and classification of bronchopulmonary dysplasia. And the second will build upon that topic and use an example of how we might leverage BPD risk based on some new work that we've done to diagnose BPD to improve patient selection for corticosteroid therapy, one of the more controversial medications that we administer to newborns. As was the case for the presentations earlier today, I'm really here representing a team of individuals. In 2011, the Children's Hospital of Philadelphia began what's known as the Newborn and Infant Chronic Lung Disease to help foster improved patient care and research centering around bronchopulmonary dysplasia, both for disease prevention and treatment. And we developed this program because bronchopulmonary dysplasia is the most common chronic morbidity that we face in the neonatal intensive care unit. And in some cases, it occurs an order of magnitude more frequently than other frequent complications of prematurity, such as sepsis and severe intraventricular hemorrhage, necrotizing enterocolitis, and retinopathy of prematurity. And we've known now for 3, almost 4 decades, that the diagnosis of bronchopulmonary dysplasia is an incredibly important predictor of neurologic disability in our patients, and it is of a similar magnitude as things that we consider to be far more germane to the neurologic system, such as severe brain injury in the forms of intraventricular hemorrhage and periventricular leukomalacia, and retinopathy of prematurity. BPD is also unique, however. We as physicians and nurses and other healthcare providers rely heavily on diagnostic tests to inform our information about the presence or absence of disease, and then establish a treatment plan. BPD, however, is one of the few diagnoses that's based on its treatment. So if we look into the neonatal intensive care unit, when we want to evaluate patients for intraventricular hemorrhage, we obtain a head ultrasound. If we're worried about retinopathy of prematurity, we do an eye exam, necrotizing enterocolitis, we get an abdominal radiograph, and so on and so forth. But we don't really have that equivalent diagnostic test for BPD. And the reasons for that, much like the pathophysiology of BPD, are multifactorial. Over the past 2 to 3 decades, research has told us that the development of bronchopulmonary dysplasia begins in utero based on a number of different factors. Prematurity is a requirement, but then inflammation and growth restriction and infection play a role. But then there's this very complex web of postnatal exposures to injurious stimuli and then disordered repair that all have to co-occur for a patient to develop bronchopulmonary dysplasia. And how we would go about formulating all of this complex web into a diagnostic test is complex. And so what we've done is we relied upon 2 of the most commonly cited exposures for the causes of BPD to be their diagnostic test: oxygen and ventilation. When Bill Northway and colleagues at Stanford University first described bronchopulmonary dysplasia as it existed in the late 1960s, children were just beginning to survive early respiratory distress and were now being supported but developing severe complications of their exposures, high oxygen and chronic ventilation. And Bill Northway and colleagues gave us a very clear understanding of the clinical, radiologic, and histological features of bronchopulmonary dysplasia, but the group did not provide a diagnostic test or a definition for the disease. It took about 12, 13 years later for the first diagnostic criteria for BPD to emerge. And remarkably, both initial criteria were published in the same journal of the Journal of Pediatrics in 1979. And they included variable formulations of use of supplemental oxygen and ventilation and radiographic findings and other physiologic measures. But this sort of diverse and complex way of evaluating the presence of BPD was simplified in nearly every publication thereafter to the use of supplemental oxygen at 28 days of age. And then over the ensuing 2 decades, there was a robust increase in technology and skill and knowledge about how to care for premature infants. And we began to increase survival, and we began to provide more intensive care to younger and younger babies. And as a result, we have increases in survival and babies making it out of the delivery room and into the intensive care unit, and now having the potential burden of experiencing chronic lung disease at younger and younger gestational ages. And this change in the epidemiology of lung disease triggered evaluation of whether or not that 28-day criteria was still valid. And this work was largely done by Andrew Shannon and colleagues at the University of Toronto in Canada. And what they did is they asked the question of whether diagnosing bronchopulmonary dysplasia based on oxygen use at 28 days of age or at an alternative postmenstrual age provided better predictive accuracy for understanding a baby's risk for a poor outcome at 1 to 2 years of age. And this is sort of a key figure that comes from that paper. And at the far left, you see there's a little dot. That's the diagnostic accuracy and performance of oxygen use at 28 days. And then as you scan to the right, you'll see that there's a number of different postmenstrual ages that they evaluated, and the age that best have amalgamated the different diagnostic performances, specificity and sensitivity and positive and negative predictive value occurred at 36 weeks postmenstrual age. And so that's become the new benchmark that's carried forward since the late 1980s. And then in 2000, a series of individuals and experts were convened to discuss the importance of BPD and sort of the ongoing need there was to develop new treatments and diagnostic criteria. And as part of that workshop, they developed the first widely used severity-graded diagnostic criteria that are shown here. And this definition says that for infants born less than 32 weeks gestational age, they must be treated with supplemental oxygen for greater than or equal to 28 days at the time of assessment at 36 weeks postmenstrual age. And if that's true, they're then categorized as having mild, moderate, or severe bronchopulmonary dysplasia based on whether or not they're breathing in room air at 36 weeks, whether they have a need for less than 30% oxygen, or whether they have a need for greater than 30% oxygen and or receiving positive airway pressure at that 36-week time point. This has really been the benchmark for how we severity grade diagnostic, or how we severity grade BPD for the past 2 decades. But just as was the case as we moved from the late 70s into the late 80s, the way that we care for babies has changed and the epidemiology of lung disease in infants has changed. And as a consequence, limitations of the 2001 criteria have emerged over time. I've listed a few of the more prominently noted ones here. It does not account for the use of high-flow nasal cannula at 36 weeks postmenstrual age. In the year 2000, this was a rare intervention. Now it's far more ubiquitous in many of our centers. The 28-day criteria to assess for supplemental oxygen use is often misinterpreted as the oxygen use on day 28, which is not how the definition was written, or it's just completely omitted altogether. And lastly, the 2001 criteria may not optimally stratify disease severity among modern very preterm infants. And there's a number of ways that we might conceptualize this, but one that I find is particularly telling is shown with these 3 infants here. So each of them you can imagine is born at 28 weeks of gestation, and I show you their photograph at 36 weeks postmenstrual age. The baby on the left is receiving 35% oxygen by 1 liter nasal cannula. In the middle, we have a child on CPAP, 6 centimeters of water, receiving 35% oxygen. And on the far right, you have a child who's receiving invasive ventilation with 35% oxygen. Each of these infants would be classified as having severe BPD by the 2001 criteria. But I think if you or I were talking to the mother or father of these infants, we would suggest to them that the baby on the left is likely to have a better outcome than the baby on the right. So what a group of us wanted to understand was whether or not we could use a data-driven approach, really for the first time, to diagnose the severity of BPD rather than just relying on expert opinion, as had been historically done, and develop a contemporary definition of BPD that overcomes limitations in the current diagnostic criteria and improves prediction of respiratory and developmental health in early childhood based on outcomes that are meaningful to families and healthcare providers, as well as organizations that approve things like medications and devices for use in the intensive care unit. So this work was published in 2019. It's a freely available journal article if you direct your computer to the ATS Journal's website or just search bronchopulmonary dysplasia and a few of our names. This is an article that you're able to download free of charge. The key questions that we approached in this analysis were threefold. The first, how best to classify infants receiving low as compared to high-flow nasal cannula at 36 weeks postmenstrual age. We then wanted to know whether there was utility in a separate severity level for infants receiving invasive ventilation at 36 weeks postmenstrual age. When we heard about resuscitation at 22 and 23 weeks, we saw a number of those children were having prolonged exposure to mechanical ventilation. Do those children represent a unique severity level? And then lastly, does the use of 28-day evaluation for supplemental oxygen help or hinder the diagnostic criteria? The next set of slides I'll show you have similar looking tables. In each of them we'll show one of 18 different definitions that we developed to evaluate for prognostic performance. Each row in the table represents a unique definition. And on this first slide, I show our first 3 definitions. Each of these was designed to evaluate different classifications of low versus high flow nasal cannula. The first one, definition number 1, was modeled closely after the 2001 NIH consensus definition, with the slight modification that infants receiving high-flow nasal cannula are grouped together with those receiving other forms of positive airway pressure, because it was not previously possible to categorize those infants based on that criteria. Then definitions 2 and 3 iterate on that diagnostic evaluation of high-flow nasal cannula based on level of flow and on amount of supplemental oxygen. The next set of definitions evaluate our second question, whether or not there's a utility for a separate severity level for infants receiving invasive ventilation. So here, we've taken all children who are on a ventilator and provided them their own severity level, first without considering the amount of supplemental oxygen they're receiving, and then subcategorizing those who may have the most severe lung disease, those who are receiving 30% or more supplemental oxygen. And then lastly, we wanted to evaluate the use of that 28-day criteria. And so these final definitions are the exact same as the first 9 that I showed you, but here we've completely removed the 28-day assessment. If you're breathing in room air at 36 weeks postmenstrual age, irrespective of what you've received before, you're not classified as having BPD by these criteria. We wanted to know which one of those 18 definitions best predicted a primary outcome of death after 36 weeks or serious respiratory morbidity at 2-year follow-up, and I'll define that on the next slide. And a secondary outcome of death after 36 weeks postmenstrual age and our fairly typical moderate to severe neurodevelopmental impairment. So language delay, cognitive delay, hearing loss, vision impairment. We did this in just under 3,000 very preterm infants enrolled in the American NICHD Neonatal Research Network. Our primary outcome, that serious respiratory morbidity that I mentioned, other than death, included tracheostomy, continued hospitalization for a prolonged period, greater than or equal to 50 weeks postmenstrual age, for respiratory reasons, use of supplemental oxygen, respiratory support or respiratory monitoring at 2-year follow-up, and greater than or equal to 2 rehospitalizations for respiratory reasons prior to 2-year follow-up. We know that infants who are born premature and those who have lung disease are highly likely to be rehospitalized, and it's an incredible burden to families in the healthcare system. So of those 18 definitions, the one that performed best is shown here. It was the best predictor of both of our outcomes. It removed the need to assess for 28 days of oxygen therapy, and it graded lung disease severity based only on the mode of respiratory support administered at 36 weeks postmenstrual age, irrespective of the level of oxygen. So if you're breathing with 1 or 2 liters nasal cannula, low flow nasal cannula, you have grade 1 BPD. If a baby is receiving high flow nasal cannula or other non-invasive form of positive airway pressure, the infant has grade 2 BPD. And if they're receiving support through an endotracheal tube and invasive ventilation, they have grade 3 BPD. These diagnostic criteria correctly classified the presence or absence of late death or serious respiratory morbidity in 81% of study infants. It's not 100%. But our ability to predict a 2-year outcome based on one data point at 36 weeks postmenstrual age, getting 81% of them correct, is quite strong. As we were doing this work, another expert consensus body formulated, sponsored by the NICHD, and they sat in a room and they came up with a series of different categorizations for infants receiving various levels of support and supplemental oxygen, and published this in the Journal of Pediatrics in 2018. Since our work followed this, we had an opportunity to compare the diagnostic performance of our test both against the 2001 definition and this 2018 definition. The C statistic is analogous to the area under the curve, right? We think about diagnostic tests, and as you get to area under a curve closest to 1, you have a better performing test. And so in both of these instances, our ability to predict a poor outcome based on respiratory morbidity or neurodevelopmental impairment or death was stronger when we applied our 2019 NRN-based definition and compared it against both the 2001 and 2018 definitions. The next set of slides will show some of the epidemiology of lung disease based on the diagnostic criteria that we proposed. And so we see here that about a third of babies born very preterm have no BPD. About 40% have grade 1, and about 10% have grade 3 BPD. And when we look at the composite outcomes that we use to develop this definition, we see, as we would like, a nice stepwise increase in frequency as the presence and severity of BPD escalates. And so, as is known to occur, some infants but few infants who don't have BPD go on to have what we would consider serious respiratory morbidity in later ages. And then we increase to about 25%, about 2/3, and then about 75% of infants as the severity of BPD increases. And we see similar gradation as we evaluate death and neurodevelopmental impairment as well. What about mortality itself? Well, thankfully, those without BPD and those with milder stages of BPD, mortality rates are quite low. But as we look at grade 3 BPD, we see 20%. That means that 1 in 5 of infants who are receiving invasive ventilation at 36 weeks postmenstrual age will die before their second birthday. Looking at the different components of our primary composite outcome, we again see that stepwise increase for each of them as BPD severity increases. Higher rates of tracheostomy, prolonged length of stay, greater rehospitalizations, things that matter to families. And most strikingly, we see a 2 to 5-fold increase for nearly each one of these as we go from grade 2 to grade 3 BPD. What about other measures of healthcare utilization that didn't factor into our primary outcome? Again, things like feeding tubes and feeding difficulties, need for home medications and treatment of reflux, a close relationship with the healthcare system and a pulmonologist and a home nurse and ICU admissions, each of them increasing in stepwise manners as BPD severity increases. We've done work to validate this definition in external data sets, looking at nearly 25,000 infants born less than 30 weeks postmenstrual age, 30 weeks gestational age in the Vermont-Oxford network. We again see increases in retinopathy, home oxygen therapy, tracheostomy, late death, and prolonged length of stay. This type of work has been done by others, including studies that evaluate longer-term outcomes and in general are consistent in demonstrating that the diagnostic criteria that we proposed perform better than other existing criteria. We've taken an opportunity to update the BPD risk estimator, and if you direct your computers to neonatal.rti.org, you can enter in a relatively small number of details about the patients that you're caring for, and you will get a predicted probability that the infant in front of you will have either mortality or the various levels of BPD severity that we've proposed. But one of the reasons why BPD is such a controversial diagnosis, right, is because, as I mentioned at the beginning, we're assessing its presence and severity purely based on its treatment. And that may not be the most objective approach. And so I like to think of this as sort of the iceberg, right? Like just saying if you're on these levels of support, we're really just getting at the tip of what we have available to us as tools: imaging, blood work, histology, response to therapies. And as part of our work at the Children's Hospital of Philadelphia, we're really trying to get to that bottom portion of this iceberg to understand how to better diagnose and treat BPD. And one of the areas where I think we're really going to see advancements in the coming decade is how we classify BPD in ways that are modeled after things like what's done with asthma and chronic obstructive pulmonary disease, where we can look into phenotypes, shared observable characteristics or traits of a disease, and the endotype, the distinct functional or pathobiological mechanisms that underlie the development and persistence of BPD. Using some diagnostic performance tests that we've done at the Children's Hospital of Philadelphia, we've proposed a 3-disease component model for severe BPD. We've used CAT scan to evaluate the presence and define the severity of parenchymal lung disease. We've used echocardiography to define the presence of pulmonary hypertension, and we've used bronchoscopy to evaluate the presence of tracheobronchomalacia. And when we do that, what we find is that there's a wide array of different types of phenotypes in severe BPD. And here we have a Venn diagram that shows the proportion of infants in our study that fell into each one of these categories. And there's 2 main take-homes that I'd like you to get from this. The first is that each possible permutation, different combination of these 3 disease components were identified. We have infants with just pulmonary hypertension and just severe parenchymal lung disease, and we have double combinations. The second take-home point I'd like you to see is that in the center of this Venn diagram, the most common phenotype among infants with severe lung disease was the presence of all 3 phenotypic components. About a third of the cohort at each of these. We've begun to evaluate outcomes associated with this phenotypic classification. And one of the things that we see as most striking is that as you increase the count or the number of the phenotype components, it appears that your likelihood of having a poor outcome increases. And in particular, as you get from 2 and into 3 components, you have much higher likelihood of having mortality, long-term home ventilation, and need for multiple pulmonary vasodilator therapies. But just as we had that iceberg analogy, right, this is moving us a little bit further down, but we still have a long way to go. And for this example, I show 6 different CAT scans. Each of these would be defined as having severe parenchymal lung disease based on the criteria we use. But I think any one of us can look at this slide and say these are dramatically different appearing infants. We have at the top left-hand side a very microcystic, homogeneous looking lung. As we move to the right, we have larger cysts, and then at the right, we have a completely blown out and simplified alveoli. At the bottom, we're looking at consolidative lung disease, and it's primarily basilar on the left, and then it moves to be in a more perihilar position. And how the morphology of this is going to impact longer outcomes and may benefit differently from treatments is really not yet understood. What we've begun to do is instead of relying on physician interpretation of CAT scans, as was done in the prior work that I've shown you, we can do much more, I think, with computational analysis of CAT scans to get values that represent objective diagnostic tests. And so we've begun doing a computational assessment of the lung parenchyma using CAT scan. And the way this works is you take a CAT scan, and then you have sort of an automated partitioning with a little bit of correction as needed, and you develop a lung density histogram as is shown on this slide. And we have an understanding of what a normal lung density histogram looks like, and we also have an understanding of when you shift that histogram towards the left or to the right, what that can mean. And as shown here, as you shift it more towards the left, we have more evidence of increased low attenuation areas or emphysematous disease. And as you move it to the right, we have more areas of high attenuation consistent with consolidated or parenchymal disease. And using this diagnostic test, we can get a bunch of different important values, such as attenuation areas, lung density, kurtosis, and skewness. And each of these provide information about the presence of small airway disease and consolidative physiology. And as we've begun to evaluate what these different diagnostic values mean, we're beginning to learn how they may impact or predict the type of lung disease that we encounter. So shown here are 4 graphs looking at low attenuation areas, lung mass, mean lung density, and lung volume, and I've color-coded them with the red ones demonstrating more emphysematous or obstructive disease, and the blue ones demonstrating parenchymal or consolidative disease. And what we see is that the increasing severity from moderate to severe in those who died is consistent with there being the presence of both phenotypic components in those who have the worst lung disease. We're also now incorporating, I'm almost done. We're also now incorporating dose-neutral dual energy CAT scans, which allow us to look at lung perfusion. So if we take a normal X-ray, right, we see some abnormalities that we can't quite localize. We get a CAT scan, we're now able to pinpoint their location better, but we don't provide information about whether or not those more emphysematous areas are participating in lung perfusion. By evaluating lung perfusion on top of our CAT scans, we're able to get a much better picture of that. And we see here with the red star, an area of the lung that has some degree of perfusion as indicated by the blue and green shading. Now take this example of a child who has a similarly destroyed area of the lung, but yet there's no perfusion to this space. In this child, we were able to unroof this and remove that large cyst and allow the surrounding areas to re-expand. And for the first time, after 4 months of living, this child was able to be successfully extubated and has been moving rapidly.
Excuse me, you are out of time now, please.
So we're going to build around this framework to look at endotypes, build phenotypic classifications, and come up with evidence-based and individualized treatments. As I mentioned, we've developed new diagnostic criteria, and we hope that advanced imaging will improve our ability to phenotype and come up with new, innovative ways to treat these children. Thank you so much. I apologize for running late.
Thank you so much, Dr. Eric.
Thank you, Dr. Eric, for simplifying the complexities of the BPD definitions. Now, before I could proceed with the next speaker, I would like to congratulate the co-chairman, Dr. Ayman Rahmani and Dr. Junaid Khan, for hosting such a fantastic event. And now our next speakers for this session is Dr. Junaid Khan, who needs no introduction. But for those who are new, Dr. Junaid Khan is an American board certified in pediatrics and neonatal perinatal medicine, and is also an American board certified in medical quality. He is the Director of Medical Education and Director of Pediatric Residency Program at the Sheikh Shakbout Medical City. And he is also an adjunct faculty member at the Sheikh Khalifa Medical University and GMU. And today he's going to talk on a very common topic of interventions, which is very common in the neonatal period, which is a non-invasive ventilation. He's going to update on this. Please join me in welcoming Dr. Junaid Khan.
Thank you very much. I will try to finish as usual, but if it's 1 or 2 minutes over, that's fine. It is very, encouraging for all of us when our juniors getting their success. I must appreciate 2 juniors today. Dr. Manzoor Ahmad is now consultant. Become a big round of applause for Dr. Manzoor Ahmad. And the second one, Dr. Mughis, is somebody somewhere sitting here. He also get the consultant license. It's a very encouraging for all of us that our colleagues are advancing. Having said that, so I am going to talk about, as Eric said, only about the tip of the iceberg. What is this? The non-invasive ventilation. Okay, so I have no financial conflict, but I will take some names of some products, which is the part of the talk. So, but I have no financial conflict of interest with those. My objective is to tell you how the non-invasive ventilation is evaluated and how you evolve and what we can do now and what is the latest therapies we can do it. So CPAP is the gold standard, everybody knows. So why we are, having this non-invasive ventilation and again and again, the CPAP is the gold standard, very well studied modality of non-invasive ventilation, but still we are looking a few things. And the reason is, before I go to the reason, I will show you some nomenclature. So these are the non-invasive ventilation. You have a different type. The constant airway pressure where the CPAP and nasal cannula, and then variable like NIPPV and BiPAP and nasal high flow. Other than that, there is, in my previous hospital, we are using a lot the NIV-NAVA, the non-invasive ventilation. It requires a catheter to put it, but it is a very good modality. But I will not talk about this today. These are the 3 major ways when we are giving the non-invasive ventilation. High-flow nasal cannula has only one limb, which is the inspiratory limb. The bubble CPAP or the CPAP through the ventilator or through other machines have 2 limbs, inspiratory and expiratory limbs, and they adjust the pressure. The blenders are must. So those who are from the low resource countries, if they want to invest in something, the blender is the one they have to invest, okay. And the NIPP BiPAP, we have a different kind of machines, or through the ventilators we can provide. Something about the hierarchy of the non-invasive ventilation. There is a lot of studies, as you can see on your right-hand side, the CPAP is a big circle. There's a lot of comparison with the CPAP with the other things. But if you go through the hierarchy, the synchronized NIPPV is coming the first, then the NIPPV, then the nasal high frequency. The BiPAP and high flow nasal cannula is not gaining that much attention, but it doesn't mean that you shouldn't use it. I will come back to it. So the NIPPV appears to be the most effective primary modality in preterm neonate with the RDS to prevent mechanical ventilation. And as Eric said, if you prevent the mechanical ventilation and the other things, the chances of BPD is low. The trends are changing. This is the recently published in the late 2022 from the UK. There's a significant increase of non-invasive ventilation support in England from 22.5, England and Wales, 22.5 to 35.1. The CPAP increased from 21.5 to 28, and high flow from 1 to 7. The high rate of high flow also requiring CPAP or mechanical ventilation within 7 days, so I will talk about this. But the trend is going toward the non-invasive ventilation. There is the pros and cons of that, but this is the way we should. So why we are talking about this? Because as I said, there's the pros and cons. This is the 2016 study with our dear friend Dr. Peter Davis group. He did a lot of his studies on that. And what we find it out, the smaller the baby, the chances of the CPAP is very high. In this study, 25 to 28 weeks, the chances of CPAP failure is 43%, and 29 to 32 weeks is 21%. The longer duration of results in longer duration of hospitalization, complication like BPD, and so on and so forth. So that's why we have to look in some other modalities. In 2020, Dr. Ramanathan, Professor Ramanathan, published all the trials and their of the CPAP and their failure rate. And these are very high among smaller babies. So as you can see at the bottom of the graph, the gestational age is 26 weeker, 29 weeker, 26, 27, 28, and this is the average, which including a very small babies. So the chances of CPAP failure is higher in that group. And this is the data from 2008 to 2013 and completed in 2020. The recent data from 2023 February, this is a very established study and is a trial in Spain, and it is reviewed and added by Dr. Martin Kessler group, who did a lot of work in ventilation and non-invasive ventilation. And what they found it out, that the type of initial thing is the CPAP, NIPPV, or high-flow nasal cannula. The type of NIPV between 24 and 72 hours is CPAP, NIPPV, and high flow. But look at the gestational age. The gestational age is very, very, as you can see here, is 26 weeker, 26 to 26, and so the very small babies, they took it. So that's how it is. And the reason that what happened to them in the first hour of life, the NIV is first hour of life, the CPAP and the NIPPV is nothing significant, a CPAP alone is not significant, and compared with the MAP is not significant. But if you go first to 24 and 24 to 72 hours, the NIPPV has some better results. Having said that, because of many other things, there is a no-brainer in that lower the gestational age, the chances of failure is high, but it is going down. And the conclusion what they make, it is going down because of other things. It goes, according to this study, is 15.6% as compared to the 23 and 43%. And it is associated by more use of NIPPV and the delivery method of the surfactant and the type of the surfactant using. So we did the workshop yesterday on the LISA. It has a promising future about that and the NIV modalities. I have bias. I trained in New York. I have bias about the bubble CPAP. It's a Cochrane Review 2023, and it's compared with the mechanical ventilator or the infant flow drive. The bubble CPAP can reduce the number, the treatment failure, and number need to treat is 20. The pressure source may not be affected the BPD, and it is the trial is published just 2023. So the bubble CPAP is a very easy way to give the non-invasive ventilation, and it's much cheaper than other modalities. So the CPAP failure, how you predict? So one, and like estimator Eric just showed about the BPD. So this is the study again in 23, and they said that the time to failure is about all infant is about 6 hours, 22 to 23 is about 5 hours, and 27 to 29 weeks is about 7 hours. And FiU2 is like 50% or 48%. But interestingly, what they said it is, we written it, that the study showed that combination of maximum FiU2 more than 0.3 within 2 hours of life and severe RDS on initial chest radiograph are the most important. So what they want to say that even if you go up to 40%, okay, and give them a chance to this thing, it will not make much difference in that age group, what I am showing. So that's the targeted values they choose. Try to keep pH 7.25 to 7.35. BPD already Eric told, so I'm just focusing initially the preterm infant. The PaO2, arterial O2 is 45 to 65, arterial PCO2 about less than 60 if it is 0 to 72 hours, and if it is more than 72, about 65. Saturation is 90 to 95 or 94% is okay. There comes the high flow. So first we have to see the high flow, washout of nasopharyngeal dead space. The dead space is much higher in newborn baby than adult. On top of that, the lung is, this I'm talking about anatomical dead space. Then on top of that, the lung is not functioning well, then they have a physiological dead space. On top of that, if you intubate, they have a mechanical dead space because all those areas has no gas exchange. So high flow help in that, increase FiO2 and reduce carbon dioxide breathing. So this is the graph showing the difference between the high flow and the low flow, that high flow has a higher airway pressure. Other than that, it reduces obstructive apnea, it stands a small airway because of higher pressure. So this is the fluoroscope gram, showing from the end of expiration how beautifully at the peak of inspiration. There are difference. So all modalities of non-invasive have difference between each other. CPAP is a constant PEEP, whatever you put, 6, 7, 5, 8. High flow has less reliable PEEP depending on the flows. Maintenance of functional residual capacity is more in CPAP, and washout of nasopharyngeal dead space is more in high flow nasal cannula, and so on and so forth as written. So these are the comparison of the CPAP. But the problem is that when we try to use as a primary in a very smaller babies, so we couldn't find any benefit over the CPAP. And this is also proven by the Australian study. You all know the HIPSTER trial. They have the babies 28 weeks to 36 weeks, and they found it out that if you use this primarily the babies, in the smaller babies less than 28 weeks, the CPAP is better. But the Italian trial, which is also showing, but the problem with the Italian trial, the babies are a little bit older, 29 to 36 weeks, and they use the vaposum. There's a machine who provide the high flow nasal cannula, and the nasal CPAP or the BiPAP level is 4 to 6. And they found it out, the efficacy and safety is similar to CPAP and BiPAP. So there's a little bit conflicting messages we are getting. The final one, which is just published in 2022, is saying that there is a dearth of data about that, but for the babies less than 28 weeks, it is not advisable to use high flow nasal cannula as a primary support. And last but not the least, the 2023 Cochrane review said the same thing. They evaluate 13 studies, including 2,500 plus babies, and they found no difference in other things like BPD or with the CPAP or NIPV. But because these babies less than 28 weeks are not that many in the study, so they are not sure, and they are still recommended that not to use in a very small babies. Let's come to the NIPPV. I'll go about that there's too many names, but the non-invasive positive pressure ventilation is the most common name. It is why and what? Because the CPAP failure rate is there, so that's why we have to see the other modalities. If we know, like many other things, we don't know, but the hypothesis is that it includes the Hertz paradoxical reflex. Those who are away from the physiology, the Herring-Brewer reflex is the inhibited reflex. You try to inspirate, take it more, and at one point you stop. Similarly, when you expire more, at one point you stop. This is called the Herring-Brewer reflex. The head paradoxical reflex is opposite to that it stimulates the breathing. So one of the reasons the hypothesis said that NIPPV help in that. Pharyngeal dilatation, improved respiratory drive, and there are some short-term effects. Pressure and volume delivery through the ventilation, the PEEP, it also act like a maintain the functional residual capacity as in the CPAP. Now, there is a more coordination between chest and abdominal movement. The abdominal is the red, and the chest wall is the green. And as you can see, the NIPPV on your left hand and CPAP on your right hand, there is a difference. So there is a more coordination. On top of that, most of our machines don't have the synchronized NIPPV, as I know so far, but even the simple NIPPV has a more coordination as compared to the CPAP. One misconception when we come to the BiPAP, whenever we do the rounds, we ask what is the BiPAP. Everybody said that the BiPAP means that there are two pressure, one is PIP, one is PEEP. It is wrong. It is BiPAP is two PEEP level. One is a higher PEEP level, but what you said, and one is a lower PEEP level. In NIPPV, you have a PIP and the PEEP. So this is the major difference between the two. On top of that, you are putting the baby on the similar type of a setting. I will go through it in a minute, and which you are putting on the ventilation. Then come to the part that if you are putting the baby with the non-invasive, did it really get some pressure? So this is the study by the Dr. Ramanathan group, and he is the invented the RAM cannula. So they look into it. The cannula size is 3. The premature baby, the nostril size is 3.4. The set pressure, if you give 15, want to give, at least you will get 11.4. If you want to give 20, you will get 15. If you want to get 25, you get 18.7. So yes, there is some difference in the pressure when you're providing with the tube or without the tube, but still it gets quite amount of pressure. Evidences, I will go through very quickly. First group is Dr. Peter Davis. They found it, they did the meta-analysis, and they found it very much difference between NICPAP and the synchronized or non-synchronized NIPPV versus CPAP, and both modalities are favor of reducing the BPD and reducing the reintubation. Then in 2017, the same group published about the post-extubation, and they again found it out, the smaller babies, if you post-extubate, if you put them on NIPPV, it is much better as compared to the CPAP. Dr. Ramanathan in 2019, I always go into the chronological order, he also found it out that many of the studies, including his study, the first one on your right-hand side, it shows that the CPAP failure is about more than that, than NIPPV. NIPPV failure is about 5 to 25% in those small babies. This is the 10 randomized controlled trials over the period of 16 years. So 2020 is the last studies, meta-analysis we receive, and goes that the NIPPV is more efficacious than CPAP. And this is the same thing. Then this is a very comprehensive article. Who are the fellows or who want to read? This is the article about the efficacy of non-invasive in 2022. They compare each modality with other, the mechanical ventilation, BiPAP, CPAP, and NIPPV, and they also find the same results. I don't have much time to go through it, but it is go in favor of those things. Mortality also published in 2021 in Clinical Perinatology, and they found it out. The ventilator-generated synchronized NIPPV can decrease the mortality in those babies. And the good thing about that meta-analysis, if you can see from the far, the I-square, which shows the heterogeneity, is 0% in this meta-analysis. So this is a really good meta-analysis. The Ramanathan group also said that NIPP versus CPAP is statistically different, and also non-synchronized or synchronized, it make the difference. So the other thing is that to put the baby in the delivery room, we don't know. There is no randomized control trial, as far as I know, of that. But there is some study which is not randomized control. They put the baby on NIPPV in the delivery room, and they found it out decreased need for intubation, 31 versus 85%, which is significant, and also decreased need for IMV, mechanical ventilation, at 24 hours of age, 38 versus 66%. So this is one of the things, but I don't know if there is a randomized control trial on that. How you put it in, what are the settings? There's a different way. If you are using as a primary, you can either take this, but maybe you decide about the pathophysiology, excuse me, and also the baby, how the baby is doing. If you put it at extubation, then these are the numbers, okay? We will send you all these protocols, and you can have it. That when you extubate the baby and you want to put the baby on NIPPV, what are the numbers you can see? And how you make the troubleshoot, if it is hypoxemia, what you should do, if it is hypercarbia, what you should do, if you have both, what you should do, and in case of apnea. So weaning of NIPPV is also very important. FiO2 less than 40, PCO2 less than 60, and pH is 7.25. It is the time to change to the CPAP. The CPAP, whether the baby is doing fine, we want the CPAP to continue to 31 weeks of gestational age, as the CPAP help in the lung growing. So please help the baby up to that age. Do not put on something which is, or without anything, or the nasal cannula, but continue with the 31 weeks around completed, or more than 30 weeks on the CPAP. The failure, again, it is different in different things, but the standard is 7.22, and the PaC2 of more than arterial carbon dioxide is more than 60, it is the time to change. But more than that, the frequent episodes of apnea and bradycardia, which is 20 seconds of no breathing and heart rate less than 100 per minute, or the frequent desaturation, it's not that some changes in the monitor happening all the time, but if it is less than 85%, 3 episodes per hour, then you think about some other modalities. So these are some setting of that. Last, I have 2 minutes only. So I have to go through very quickly nasal high-frequency oscillation. This is the supraglottic high-frequency oscillation and super CPAP. There are some studies showed in favor of that it is help in improving the carbon dioxide elimination, as this study by Dr. Mukherjee and Daniel D. Lucchi in 2016. It shows that the CPAP, if you have the problem only with the carbon dioxide, then before intubation, you might try it, but we are not using it right now. Another study by China in Zhu et al., what they said, primary nasal high frequency versus CPAP, and as you can see in the graph, that the BPD, they show that it is less than 8.1 as compared to 12.8 in the CPAP group, and also need for invasive ventilation drop from 57% to 25%. So there are some, interesting things about this one. Now, the proof of efficacy, which is by Dr. Klotz in 2018, and this particular study is showed no difference even with the CPAP. So again, there is you have to do the balance between these study and look very careful the evidence, critically read those evidence before you apply that. So there are many studies on that. The suggested setting, we are mostly using the Draeger. So we are, the rule is lower the frequency and longer the inspiratory time. So these are some suggested setting of that. So the summary of evidence, yes, in vitro they have a good data. Few studies suggest in favor of nasal high frequency. But these are the two studies going to publish very soon in 2023, and application, this one, the first one, it compare all three modalities, and the second one is optimal trial. So last slide, European consensus guidelines just published 2022 after almost 5 years. CPAP or NIPPV, the recommendation level is A1 if it's a baby less than 31. Technique to give surfactant is LISA, and the type of surfactant is poractant, is again A1. The system delivering the CPAP is little importance. However, the interface should be short binasal position or mask is A2. The ability to escalate to NIPP will reduce the need of invasive, and the BiPAP has no confer advantage over the CPAP alone. So this is my summary. I have time out, but this is 1 minute that what you should do as we heard about the future delivery room and the delivery room. So right now, for us, the delivery room stabilization is very important. Start with the CPAP, then try as much as non-invasive, bring the baby to the NICU on the CPAP, use TP resuscitation, try to keep the saturation stable. The preductal, we are looking into it, avoid prolonged hypoxia. If you have to intubate, you will not try again and again, just stop it and then seek your help. If you are good in providing the PPV, you can save the life because the hypoxemia is the much more killer than your anything else. Try non-invasive, try NIPPV in a baby less than 28 weeks. Mechanical ventilation, you have to give the tidal volume. And if the surfactant administration, so this is the point, that do not allow too much high oxygen. Many centers is allowed. As I showed you, there is no difference if the baby requiring more than 30% and the CPAP of 6 or more, then give the baby surfactant and continue with your non-invasive ventilation. Do not intubate the baby. So my conclusion is NIV is an important tool. It is considerable difference in the clinical evaluations of different methods. NIPPV is preferably in less than 27, both as primary and post-extubation. But the last 2 points is the most important. In clinical practice, the choice of the applied technique should depend on the underlying pathophysiology. And the most important for the successful as NIV, the team knowledge and clinical experience with the method and the device used. So thank you very much. I will finish here, and happy Nurses Day again.
Thank you, Dr. Junaid. Excellent presentation. I think you summarized and put the evidences for NIV, and that's the take-home message for everyone. And everybody, probably going to use NIV, and they are using it. And with that note, I think I have again time to invite Dr. Eric again to complete his talk on BPD. I think he talked about the definition, and now he will be talking about the most controversial, topic or the subject, steroid use in BPD. Dr. Eric, the floor is yours.
Thank you again. I have no disclosures. So, as we mentioned earlier, inflammation has been recognized over the past 2 to 3 decades as a key driver in the development of BPD, and as a result, Corticosteroids, with their potent anti-inflammatory properties, are a logical medication for us to use to try to prevent bronchopulmonary dysplasia. But despite enormous effort to study these medications, greater than 80 randomized trials, greater than 9,000 infants enrolled into these studies, as Lex Doyle tells us, we still don't have clear answers about who we should treat and when we should treat them, and if we're going to, what medications and doses we should use. So as sort of an outline for the next 20 minutes or so, I would like to go through what evidence we have and some new evidence that we've just developed about who we should be treating, when we should treat them, what drug we might use, and what dose might be appropriate. Of course, this comes with the disclaimer that the answers that I'll provide for you are only as good as the data that we have available to us. And I think to get through those 4 questions, it's really illustrative of us to go through the history of corticosteroid use in premature infants. The first study that I can come across that evaluated dexamethasone is this one published in Lancet in 1983, and it enrolled 6 infants. It was a crossover trial that compared dexamethasone with placebo, 0.5 milligram per kilogram per day for 3 days. And what they demonstrated after having to stop this study early because of its tremendous benefits was that there was reductions in positive inspiratory pressure and significant reductions in the amount of inspired oxygen. This then moved the field forward, and in the late 1980s, Jim Cummings and colleagues published their paper in the New England Journal, which evaluated a 9-day course of dexamethasone, a 42-day course of dexamethasone, which resulted in nearly 9 milligrams per kilogram total exposure to controls. And they found significant reductions in the duration of ventilation, the duration of oxygen therapy, and the length of hospitalization when we gave a prolonged course, high levels of dexamethasone to infants. And the result of these discoveries was a rapid rise in the use of dexamethasone to try to prevent bronchopulmonary dysplasia. And the prevailing opinion over that decade was that if we give a little steroid and we have good outcomes, maybe bigger doses and earlier treatment must be better. But there was a very significant corrective step that happened soon after this. And the first discovery was published by Dr. Ye and colleagues when they did 2-year follow-up of their randomized control trial evaluating 130 surviving low birth weight infants. They used lower doses, but ended up having about 6.2 milligrams per kilogram over 49 days, so a bit lower than the Cummings regimen. And they found a substantial increase in the risk for neurodevelopmental dysfunction. And around that time, there were a number of animal studies looking at what happened when we exposed at-risk fetal lambs to single courses and prolonged repeated courses of dexamethasone, and there was significant growth restriction in the brain and cerebellum in particular that was far more pronounced when they looked at preterm lambs than term-born lambs. So as a result of these discoveries, in the year 2002, the American Academy of Pediatrics issued a policy statement that said that the routine use of systemic dexamethasone for prevention or treatment of chronic lung disease in infants who are born very low birth weight is not recommended, and other governing bodies throughout the world issued similar recommendations at similar times. And this was a rapid course correction to the point where a decade of increase in steroid use was rapidly changed, and now we're back to levels that predated those seen in the early 1980s. But as a result of this, there were several unanswered questions. And one of the most dramatic effects of that embargo on the use of corticosteroids was the early stopping of the dexamethasone randomized trial, or DART trial. I imagine many of us are still using this regimen in our units today. They enrolled extremely low birth weight infants. They were ventilator dependent at a week. They gave very low doses, 0.89 milligrams per kilogram, and had a goal of enrolling 814 infants. But over a 2-year period, based on the data that were coming out at that time, they had substantial difficulties in enrolling infants, and the trial stopped at only 70 infants. So those of us that are using this regimen, and I'll raise my hand that I'm one of them, are basing their decisions on a very small, underpowered trial. They demonstrated that there was a substantial reduction in extubation success with the use of the DART regimen, but there was no benefit observed for BPD, severe BPD, or home oxygen therapy. But during that time, when folks were unable to do randomized trials on corticosteroids, they began to look into the data that we had. And one prevailing observation was that BPD is bad for your brain. Corticosteroids also bad for your brain, but is their ability for us to balance these two competing forces and come up with a happy medium. And there were a few important discoveries. One was that the timing of corticosteroid administration may be important. We learned that giving dexamethasone early in life, within the first week to ventilated babies, probably predisposed them to the highest risk and shouldn't be used. There was, however, observation that giving it after the first week may not be as harmful, and we did not yet find evidence that giving it at that age increased risk of cerebral palsy. The other thing that Lex Doyle demonstrated for us in a now landmark meta-regression was that when we plotted the risk of an infant for developing BPD, that the risk of developing cerebral palsy, as shown on the y-axis here, was inversely associated with that baseline risk. So as children became higher risk for developing BPD, the risk to benefit balance shifted, favoring the use of corticosteroids in those more at-risk infants. And this then led to a new policy statement that came out from various governing bodies. And in 2010, the AAP said that clinicians must use clinical judgment when attempting to balance the potential adverse effects of glucocorticoid treatment with those of bronchopulmonary dysplasia. It's not a full you can't use them. Now it's a balancing act. And we see an increase then in the use of corticosteroids after these statements came out. But a question that's come up is, did the existing trial data support the hypothesis that low-dose dexamethasone administered after 1 to 2 weeks of age in ventilator-dependent infants is safe and beneficial for BPD prevention? And I think it's reasonable for us to question whether or not the prior trial data are applicable to the way that we practice today. I show a chart here demonstrating the dose, the total dose of corticosteroids along the y-axis, and then the timing of initiation. And these are all trials that were included in Lex Doyle's meta-regression. And I've highlighted the DART one as sort of the reference point, right? And what you see here is that many of the trials began therapy earlier than what we would consider recommended now, and or at considerably higher doses than what we consider the benchmark intervention. And so we wanted to answer this question: how should we balance the potential risks and benefits of corticosteroids used to prevent BPD in contemporary practice, where we are typically using lower doses, often less than about 1 milligram or so per kilogram total, and we're initiating that therapy after a week? The results of that have recently been published. They're available online free of charge at JAMA Network Open. And what we did in this study is we tried to determine the effect of an infant's pre-treatment risk of death or grade 2 to 3 BPD, defined as I showed in the previous talk, on the association between postnatal corticosteroid therapy and the risk for death or moderate to severe neurodevelopmental impairment or death or cerebral palsy using the NICHD Neonatal Research Network. We did a retrospective cohort study, and we propensity score matched infants using 39 fixed and time-varying variables. We're trying to get as close as we can to a randomized trial environment. We had 482 infants who were treated with systemic corticosteroids beginning between 8 and 42 days of age, so only those treated after the first week, and we matched them to 482 untreated controls. They were all born between 2011 and 2017, and these are small infants. And I re-show you Lex Doyle's graph because we modeled our approach based on theirs. And so on the y-axis, you see the risk difference for death or cerebral palsy, and on the x-axis, you see the rate of BPD in the trial control group. That's the baseline estimation of risk in those patients. What we've done in our study is we've estimated using model estimation and those variables that I mentioned, those 39 fixed and time-varying variables, to come up with a risk difference for death or NDI at 2 years of age. And then we plotted that against the estimated risk of BPD, grade 2 or 3, or death, using values recorded in the untreated matched controls. And what we find is a very similar relationship to what Lex Doyle discovered. We have that inverse looking line. We have a negative slope, and we see that for each 2.7% decrease in the risk of death or NDI, that drops by that proportion with each 10% increase in the pretreatment risk of death or grade 2 to 3 BPD. And the inflection point, the point where that line crosses the axis, is at about 53%. And if you're looking for a conservative threshold, it's about 61%. We see a similar relationship when we restrict it to death or cerebral palsy. a 3.6% decrease in the risk of death or CP, with each 10% increase in the pretreatment risk of death or grade 2 to 3 BPD, with that inflection point occurring at about 40% baseline risk and an upper confidence bound of about 46%. Strikingly, we have very similar results. We're right at about 50% for the point that we cross, and we have just the exact same number, a 3.6% decrease in the risk of death or CP, with each 10% increase in BPD risk discovered by Doyle and colleagues using their trial data. So who should we be treating? Well, I think the data now, trial data, newer observational data, suggest that ventilated very preterm infants who have about a 50% risk or higher of developing death or grade 2 to 3 BPD are the most likely candidates. When should we give the medication? If you want to use these data to estimate risk in your practice, I mentioned earlier the estimator. This is a nice way to do it. Another option is to evaluate the rates of BPD within their own unit and come up with the baseline risk in your population. So we mentioned earlier that we're not supposed to be giving steroids within the first week of age, owing to the risk of higher rates of death and cerebral palsy. After the first week, it appears to be more appropriate. We evaluated the timing of postnatal steroid use using the NICHD data in a recently published paper. And what we found is that when we begin therapy after the first week, that there's a relatively stable rate of developing severe BPD up until about week 5. And then there's a fairly rapid rise in the probability of developing severe BPD when therapy at first use is initiated after that age. It's a more subtle curve, but when we look at the probability of neurologic impairment, we see that same similar trend, that we have a fairly flat rate up until about a month of age, and then a more substantial rise. And so I think the preponderance of data now tell us that we shouldn't be using steroids within the first week, but really their likely optimal efficacy is most likely restricted to the first month of age in terms of at least BPD prevention. So what medication should we use? So this is a 2021 Cochrane review published by Lex Doyle and colleagues, and they looked at the timing and also the medication that was administered. And they demonstrated that while dexamethasone is efficacious within the first 7 days, we've learned that we shouldn't be using it then. However, they did demonstrate that dexamethasone was efficacious for preventing BPD after the first week of age, but in both instances, early and late use, hydrocortisone was not associated with a reduction in the risk of bronchopulmonary dysplasia. We evaluated that same type of question in the JEMMA Network Open paper that I mentioned earlier, and we demonstrated that there was only evidence of an improvement in the risk for death or CP with the use of dexamethasone as compared to no treatment. And this was restricted to those who had a greater than 65% baseline risk of death or grade 2 to 3 BPD. We did not find this similar risk relationship when we looked at the association between this outcome and hydrocortisone. The one caveat to this is that the Premaloc trial, published in 2016 in Lancet, evaluated 521 infants, administered hydrocortisone really within the first day of life, giving placebo as the control and evaluating survival without BPD as their primary outcome. They demonstrated that there was improvements in survival without BPD, so less BPD in the hydrocortisone group, no difference in neurodevelopmental impairment, but there was evidence of an increased risk for sepsis among the highest risk babies who received hydrocortisone. However, it's important to acknowledge that that trial has been included in the 2021 Cochrane review, and when we aggregate the data across all existing trials, there's no evidence that hydrocortisone, when administered in the first week of life, is effective for preventing BPD. So what drugs should we use? At the moment, I think the preponderance of evidence suggests that dexamethasone is the more effective medication until we have more corroborating evidence that would repeat something like the Premaloc trial to give us information that it's effective as a therapy. So the next question is, which dose should we use? And I think this is the most challenging question to answer. Just recently, the AAP published another guideline surrounding the use of postnatal corticosteroids, and they note in it that the authors of a 2017 Cochrane review analyzing randomized controlled trials that compared different dosing regimens concluded that recommendations on the optimal dosage and timing could not be made, but they suggested that both the dose and the duration should be minimized. Is that supported by the data? Well, if we take the dexamethasone data and stratify it based on the cumulative dose that was administered, I show you here the trials that looked at less than 2 milligrams per kilogram total, between 2 and 5 milligrams per kilogram, and greater than 5 milligrams per kilogram. And as you can see, only the trials that gave 2 or more milligrams per kilogram total dose had evidence of a reduction in the risk of developing bronchopulmonary dysplasia. So while it's easy to look at the overall summary treatment effect and say dexamethasone given after the first week of life is effective for preventing BPD, as you drill down further into the data, you see that that may not necessarily be true for the lowest doses that have been used. And as I mentioned earlier, the DART paper has demonstrated a clear benefit for increasing the likelihood of extubation success, but it does not provide evidence that we then translate that benefit on the short term into the longer term reduction in BPD. We've done some work using data from our own center where there's a fair bit of variety in how folks are treating infants with severe lung disease and trying to prevent and cure BPD. And this graph here shows the physiologic change in diffraction of inspired oxygen among patients that received shorter courses, less than about 10 days, 2 weeks plus courses, and those that received greater than almost 3 weeks. And in each instance, there's a fairly rapid reduction in the amount of inspired oxygen that occurs within the first 4 to 6 days or so. And then after that, there's a fairly flat curve thereafter, even among infants who receive prolonged courses. When we look at the total dose, we again see that same trajectory. So infants who received less than about 1.3 milligrams per kilogram total dose have a very similar trend in their oxygen need as do those who received higher doses than that. And so what do we know about what dose? Well, as I said, this is the hardest one to really answer. It's clear, I think, from the data that we have that it's very likely that low-dose dexamethasone has a short-term physiologic benefit. However, the optimal dose to prevent BPD is largely unknown, and the data would suggest that if that's our goal, we may need to be doing randomized trials that are willing to investigate higher doses than we, at the moment, likely feel comfortable with. So to conclude, and buy back some of the time I took of yours earlier, systemic corticosteroids have potent effects on the respiratory function in ventilator-dependent preterm infants, but we know that they can cause brain injury. I think recent discoveries, including those that have come out of our institution, may help clinicians balance these difficult trade-offs and discuss with families why they may or may not want to give permission to use these medications. And in reality, further large, well-powered randomized trials are going to be needed to define the optimal drug, dose, and timing of corticosteroid therapy to prevent BPD and not just get the short-term benefits of earlier extubation and reduction in oxygen requirement. Thank you again for the opportunity to be here. It's been a great pleasure.
Thank you, Dr. Eric, for simplifying the effect of steroids in the role in the management of BPD. Now, again, it's my immense pleasure to welcome the next speaker. I would like to welcome Dr. Ayman Rahmani. Dr. Ayman, for those who do not know him, but definitely 100% of you know, so just as a brief introduction, he obtained his American Board of Pediatrics and Neonatology from US, and currently he's heading the Department of Neonatology at the Tawam Hospital, Al Ain, and is also an Associate Professor of Pediatrics at UAE University and Sheikh Khalifa Medical University. Today he's going to talk on a hot topic that is the impact of RSV infection in neonates. Please welcome Dr. Ayman Rahmani.
Assalamu alaikum. Thank you, Dr. Manzoor, for introduction. I know it's late in the afternoon, so hopefully after this, you're going to be resting for a while, go for lunch. So I'm just going to continue the journey of the baby from the time that Dr. Faisal saved at 22 weeks gestation to Dr. Eric, first Dr. Junaid ventilated him non-invasively for a while, but he failed, so he maybe have a BPD. And then Eric treated him with steroids. Okay, so everybody's happy, the baby's ready to go home. And what happened after that? So we, as a neonatologist, we feel like we completed our task by babies going home. I'm here just to kind of give you an idea that we actually responsible for the babies after they go home. And one of the things that really heartbreaking for us is that after all this effort that Dr. Faisal, Dr. Junaid, Dr. Eric spent on the babies, that they get sick and they come back to us. So my talk today is about the RSV burden, and we think that RSV is only pediatric issue, not a neonatal issue per se, but maybe it's not. So I will start with the case presentation, and then I'll talk about the impact of RSV, both in the US as a global and as a global burden. Who we consider as a high risk for RSV infection and why the babies who are premature are more prone to have RSV infection and more severe RSV infection than the full-term babies. Also, I'm going to touch base on some of the chronic and genetic diseases that makes the babies more at risk for having RSV infection. They talk about long-term morbidity and prevention measures, and then I will just give you some studies about the COVID link, because we all lived through COVID. That's why we all here today. Alhamdulillah, we are all gathered together. But during COVID, there was change of dynamic of the RSV infection. Now it's coming back actually at a more forceful way. So I'm just going to start you with the case presentation. A female infant was admitted from home 2 days after discharge from NICU. A former 32 weeks gestation, now 36 weeks corrected age. Admitted to SCABU with current attack of apnea. And when we talk about apnea and coming back from home and premature babies, we always think infection, neurology, seizures. So the babies was admitted to rule out seizure. And on day 4 in SCABU, noticed to have cough and respiratory distress. Start wheezing excessively with excessive secretions. She was transferred to NICU, and she was in isolation for ventilation and suspected RSV pneumonia. A nasopharyngeal swabs collected and sent to the lab, and RSV diagnosis was confirmed. So this baby actually exposed other babies in the unit, because if you have unit like us, we have 6 babies in one room. So by the time you figure out that this is a respiratory disease, then all the babies going to be exposed by that time. So RSV, as you all know, it's an enveloped single-stranded negative polarity RNA paramyxovirus family. And it comes in seasons. And we have to be careful with the seasons, because for every region, it have its own season. So we kind of think that seasonality of the RSV is November to May, but it's actually not all the time. So if we consider ourselves as Philadelphia, and we're a northeast part of the US, yes, you have a seasons between November and March, but we are not. We are kind of more like Florida for US. So our seasons actually extend more from July to almost February, March. So we have actually an epidemiological way of defining the beginning of the season and end of the season by the number of positive cultures that we do, but that's kind of beyond the topic of this. So when you think about seasonality, is just think about the region you are in. So the impact of the RSV in the US is, this is just from the CDC website. It's a leading cause of lower respiratory tract infection in infants and young children. Every year, 4 to 5 million children younger than 4 years acquire RSV infection. Not all of them get sick, but a fair number of them get sick to be admitted to the hospital. More than 125,000 hospitalized annually in the US. What about the global burden of RSV? It's an important cause of morbidity in babies, in children, especially in infancy. So this is the third most important cause of death in infants after pneumococcal pneumonia and Haemophilus influenza. And the first viral cause of death in babies under age of 1. So the symptoms varies. You have acute lower respiratory tract infection, the global burden of 33 million per year cases in all over. Severe part of it is about 10%, that needing hospitalization. And annual death attributed to RSV is about 60,000 to 199,000 babies annually, globally, will die from RSV. A meta-analysis published in May 22 looked at all the studies that published about the global burden of RSV, total of 418 studies, and pretty much the same numbers that they were listed previously. So, but important thing is of their findings is that 20% of the cases of lower respiratory tract infections happen in babies under 6 months of age. And the hospitalization peaked between 0 to 3 months of age. 26% hospital admissions have hypoxemia, requiring oxygen, and case fatality rate was between 0.1 to 1.4. If you correct that to the 0 to 3, the case fatality rate will be about 10 times that, about 1.1%. Who is considered as a high risk for RSV severe infections? Premature infants, babies under 6 months of age, less than 2 years of age with chronic lung disease, BPD, congenital heart disease, and babies with suppressed immune system. Also, babies with neuromuscular disorders, including those who have a problem with clearing mucus, just as cystic fibrosis, they will have a high risk. So how the babies get infected with RSV? They get inoculated by transmission from either family, depends on the community exposure, hospital exposure. If you have an innate immunity with enough antibodies, you may stop there and you don't get to even the upper respiratory tract infection. But if you get upper respiratory tract infection and you have maternal antibodies, you get less severe infection and you get only upper respiratory tract infection and you stop there. Or if you've been immunized, if your premature babies qualify for immunization, then you protected from the lower respiratory tract infection. Now, if you don't have that, you develop lower respiratory tract infection. If you have enough cellular immunity, including a mature T cells, lymphocytes, then you don't develop respiratory failure. But if you're not, then that goes into respiratory failure and death. And between that, if you hospitalize and you can get antiviral treatment, then that will prevent the respiratory failure and death. Why premature infants as a higher risk for severe respiratory tract infection? Because they have reduced lung capacity and they have increased airspace thickness. So there's less capacity for gas exchange. That's why they get hypoxemic when they get infection and they require oxygen. Also, we know that the transmission of immunoglobulins happens mostly in the third trimester. So if the baby is born before the third trimester, they will get lower levels of IgG and they will have inadequate immune responses. So maternal antibodies transfer in utero play a significant role in protection of the babies from the RSV infection. We know that most of the transfer happen in the third trimester, more than 28 weeks. Antibodies at birth are proportional to gestational age and also related to the birth weight. So if you compare the IgG between the babies who are born less than 28 weeks to the baby who's born at terms, we see that the IgG level is almost 5-fold in the babies who are born full term, and that will make the babies less than 28 weeks born as a disadvantage of fighting infection, and among them is the RSV infection. Also, the RSV can have a more significant effect on the babies with PPD, with interrupting the lung developments. We know that babies, when they're born prematurely, they're not in alveolar stage. Alveolar stage happens around 36 weeks. So most of them have alveoli, but they're not really completely formed. So we kind of ventilate the babies at either canicular stage or saccular stage. It depends on how premature they are. And if you have an infection, that would interrupt the development of the normal lung into, when you get the infection. Just my screen went blank here. I said, make sure it's okay. So anatomical factors of lung infections. You have a baby who's born premature. They have a less lung volume, there's less lung weight, and there's less alveoli. And the diameter of the alveoli is smaller. Here we have a comparison between the babies who have chronic lung disease and the RSV hospitalization. And we see that the most pronounced here, the bronchopulmonary dysplasia. You have a significant number of the babies will get ICU admission and needing mechanical ventilation. And they have more predominant numbers. And other pulmonary malformation also play a role in hospitalization, but the more that you see it when the PPD. This is a busy slide. I hope that it projects well. But this is the baby who are born with Down syndrome, less than 2 years of age. This is a systematic review of meta-analysis looking at hospitalization, hospital stay, assisted ventilator requirements on the babies who are acquiring RSV between babies with Down syndrome and other babies. And you find across the board, you have the relative risk is either twice to 6 times the normal babies. Also, there's a new high-risk groups for severe RSV. That's the babies with inherited immunity disorders, such as DiGeorge syndrome, SCIDS, babies with bone marrow transplantation, or solid organ transplantation, HIV infection, and other immunodeficiencies that affect the baby's risk of developing RSV. Long-term effect of RSV. RSV does not end when babies recover and go home. It's actually cause long-term morbidity. And this is a long-term follow-up of babies with RSV. And this, on the left, you see that the 1 year to 3 years to 5 years to 8 years follow-up, even into adulthood. And you see there's increased risk of asthma, increased risk of wheezing for most of the studies that's reported in this meta-analysis. Here showing the asthma and wheezing in another meta-analysis, and then it looks like its odds ratio is almost 4 if you have RSV to have wheezing in the future. So this is just about the review of who would have high risk disease or severe disease and why. Now, how we can prevent it? We have actually few outbreaks of RSV in our NICU about 2 years ago, and it was very traumatic for us to contain and to get rid of. So hand hygiene is the most important part of the prevention, and also antibodies against RSV. So I'm going to talk a little bit about each with the 10 minutes I have left. So just infection control facts that RSV is transmitted by droplets and large particle. And it lives on our hands, on our stethoscope, on our pens, on our ties for a long time. 4 hours in a porous substance. 7 hours in the stethoscopes or the cows that we use for rounding, and 1 hour on the skin. So that's why hand washing is very important. We don't allow stethoscope and other things that comes from outside in our unit. Over 50% of medical personnel are infected with RSV during RSV season, so we all kind of contribute to the spread of RSV to the babies. And nosocomial infections is very major problem because the babies in the unit are higher risk and they develop very severe disease. Now, we all emerging from the social distancing, and actually this is the comparison of the RSV between pre-COVID and after COVID. As you see, the adult part, it's pretty much the same. I'm sorry, the adult part is very significantly lower on RSV pyramid. If you compare before, during the RSV season and before the RSV started, because of the social distance and the use of mask and not really a lot of, you have a lot of regulations of mixing and that. So, just this to show you that RSV was contained for most part during RSV season. What happened after we get out from RSV, this is a study, we have another one, Japanese study, but this is a European study that compared all European countries, RSV into the seasons prior to COVID and during COVID. The one on the left is, sorry. The one on my right, your right, is the COVID or during COVID time. So you see all countries, they have a decrease in the occurrence of RSV during that. Then what we do, hand hygiene is the first, pillar of prevention, and the other one is improving the antibodies or immunity in the babies who are high risk to develop RSV. So here's the serum concentration. They look at serum concentration of the antibodies of the baby who acquired RSV and not acquired RSV, and you see that the babies without RSV, they have about 4 times the antibodies titers in their body. So presence of antibodies in your blood is very important factor for not transmitting RSV. Now, if we think that most of the babies, when they get RSV, this happens in the first 60 days, this is a study that showed that most babies after discharge from the hospital, they get readmitted within 60 days with RSV. If they were admitted for RSV, they will be within 60 days. Not all of them will get admitted, but if they get admitted to RSV, they will get within 60 days. Of course, breastfeeding. I think every lecture should have the benefit of breastfeeding. Breastfeeding is protective, and if you look at this, this is the risk probability of hospitalization with RSV. And if you look at the red line is the mothers who never breastfed. They will have much higher risk of hospitalization with RSV than if you exclusively breastfed. And in between, if you kind of mixing breastfeeding and the formula. So RSV infection after we finish COVID-19, we have a resurgence of RSV. Everybody experienced it probably. We experienced it at Tawam, and we are very busy in the ER and PICU. And this happened after the lockdown was ended, and people just wander around without masks. Here's a study from Japan that's published recently about post-COVID. And you see that number of infections is skyrocketed in 2021. That's as the people emerging from the COVID. And this is the comparison between 2021 to previous 4 years. So AAP, you probably all know about the RSV prophylaxis recommendation for AAP. We had the recent one was 2014, and now there are an update in 2022, which is not really that much difference from the 2014, which emphasize on giving palivizumab to babies who qualify for the prophylaxis, the higher risk babies. So in conclusion, RSV in neonates increase the morbidity and mortality. Premature infants are a higher risk of severe lower tract infection. Lack of immune protection plays an important role in the pathogenesis of the RSV. RSV disease increases with chronic disorder, and prevention depends on two pillars of infection control. The most important things is hand hygiene and hygiene in general, and the other one is increasing immunity by inducing antibodies response. Following COVID pandemic, we have to be it's very important to not miss babies when they discharge from our NICU. And just, a note to, because I have 3 minutes left, so I might finish, so I have to say something different. When we discharge babies from NICU, it's very important to give the RSV prophylaxis 48 hours before at least. Don't leave it until they're 1 foot out of the door and then you give it the RSV prophylaxis, because those antibodies have to have time to kind of circulate, and you cannot really wait until the last minute to do it. So you have to do it at 48 hours. Minimum, we said for 24 hours, 48 hours is better. So we have to be very careful, and we have to be be very careful with the visitation and with the contact, because RSV in our area here is more than the 5 months that it's in Philadelphia, for example. Thank you very much, and I'll be happy to answer questions.
Thank you, Dr. Ayman. As usual, all your talks are very interesting and well presented with evidence-based. I think now the floor is open for questioning and discussion. All the presenters, may I request them to come to the stage, please? Dr. Eric? Yes? I think you have a question, but yeah. First question.
Yeah, my question is to Dr. Eric. I'm Dr. Maurice from Dawam Hospital. Dr. Eric, thank you for a very nice review of BPD. Evidence is very clear that dexamethasone is very effective treatment after the first week of life in prevention of chronic lung disease. There is one meta-analysis, it was published in 2021 in JAMA, in which there was that showed that if you use the physiological doses of hydrocortisone, like 1 milligram per kg, during the first week of life in a very small babies, like 23 to 25 week of gestation, who are at a high risk of BPD, they can live or they can survive without BPD. So what is your opinion about that prophylactic use of hydrocortisone in that smaller babies group?
Yep. Thank you for the question. I guess I'll have two comments on that. One, it isn't clear to me that it's really prophylaxis for anything. We think about these children as being adrenally insufficient. That's the motivation for giving a predominantly mineralocorticoid medication and hydrocortisone. But yet the majority of babies that are born that tiny don't have other outward signs of being adrenally insufficient. Many of them have reasonably reassuring blood pressures. They don't have electrolyte abnormalities that would be consistent with that. I do think that there's a possibility that giving hydrocortisone early, beginning within the first 24 hours, may well be beneficial. When we look at therapies that are effective for preventing BPD, almost uniformly they have to be given soon after birth. Caffeine given very early is more effective. Use of CPAP within the delivery room has been shown to be more effective. And so it makes sense to me that starting a therapy very early on would be the most efficacious. Whether or not hydrocortisone is going to provide that benefit, to me, I think the literature is not as clear as we would like. When you combine more recent trials with older data, the signal is far more muted. And I hope that there will be another larger trial that will come out to help corroborate that. Because when we look at giving it later, the Wes Onland trial and the neonatal trial written by Christy Waterberg suggests that giving hydrocortisone after the first week is really not beneficial at all. So we need to study that early time frame. But I'm a little skeptical that one medium-sized trial has proven its benefits.
Thank you very much. If you allow me, can I ask?
Yeah, just comment on that. So Maurice,
We can't hear.
yeah. So Maurice, on that hydrocortisone, we have some trials on that. This is only one trial. First of all, hydrocortisone is a very strong medication with the hypertension and the hyperglycemia. These babies are very fragile to that. And there is one trial which showed the increased risk of sepsis in that. So as Eric said, there is one trial going on called PLUS trial, which is to give steroid plus the surfactant together at the time by the Dr. Peter Davis group in Australia. So we have to wait on that. Yes, you
If you allow me, the next question to Dr. Junaid.
Oh, okay.
Dr. Junaid, we know that for the last 10 years, the non-invasive ventilation is everywhere. And I have noticed in my own unit that we are moving away from using the variable CPAP, the proper CPAP machine. And our all RTs, they are putting all babies, like 32 weekers, 33 weekers, 29 weekers, to all non-invasive respiratory support that is non-synchronous and is a constant flow kind of CPAP. That is resulting in a lot of abdominal distension, feeding intolerance, and SIPs. So did you come across with any study which has compared the variable CPAP with this non-invasive ventilation in terms of short-term outcomes? I'm not talking about the BPD or deaths.
Yeah, so the short-term outcome is in all studies is the same. Okay, the only thing, even the chances of having BPD is the same in the CPAP group and this thing in the NIPPV. But the failure to intubation, to get the intubation within 72 hours or within 7 days of life is much lesser in the NIPPV group.
Yes.
So indirectly you can say that it is happening. I didn't come across any other thing, but the other secondary outcome is the same about this thing. As I said, that this is the recommendation of European guidelines also, and the CPA, the Canadian Pediatric Association also, that NIPP should be used in a smaller baby as compared to the bigger babies. Bigger babies, if you are looking into it and then they are not doing well, then I think it is better to give early surfactant and then see how they are doing it. Okay? So this is my answer to your question.
You still support to use the CPAP conventionally as a first-line treatment?
CPAP is a gold standard.
Yeah.
But
Thank you very
for
much.
smaller babies, we are using NIPPV more than that, less than 27, 26 weeks.
Thank you very much.
Thank you all for such informative talks. I have just two questions for Dr. Ayman and one for Dr. Eric. Now, Dr. Ayman, for RSV season, as you mentioned here, is quite different from other parts of the world. It's longer. Do you think that this might initiate a step to change the guidelines? You know, we are allowed to give only 5 doses of RSV prophylaxis for those vulnerable babies. Do you think that we might need to change this? And the other part of the question regarding the new RSV vaccines, do you think that there will be a game changer for if they are given to the pregnant ladies?
Can you just repeat the first question?
The first question about the RSV season here in UAE.
Yeah.
As you said, it's longer, so we usually give 5 doses as maximum for to prevent RSV.
Yeah, so 5 doses are the standards right now. There was some discussion in the 2022 guidelines that to extend beyond the five months, but eventually they recommended 5 months. Now we, in the DOH definition of the beginning of the season, does not really go rigidly on one date. They have epidemiological definition of the start of the season, which is if you are more than 10% of your sample, respiratory samples of respiratory diseases becomes positive for RSV, then you announce the start up of your season. When it's at the end of the season, if it's less than 10% of your samples come back positive, then that's the end of the season. The season can be less or more than 5 months, but So far, the recommendation from the AAP, the old recommendation and the new, 2014, by the way, is we're not implementing in our guidelines. We're still on the old one, which is more liberal. I think we should be more liberal because there's a lot of studies showing peaking of ICU admissions and severe diseases after the restriction that came in 2016 guidelines. So we're still on the old guidelines. Now you can have a modification of the guidelines, depends on your where you live in the season.
And RSV vaccines?
RSV vaccines, we keep hearing that's coming. If it comes, that would be great, like invention, because then you require to have only one vaccine for at least for the season, instead of 5 separate shots.
One of them was approved already, but it's not for pregnant ladies.
No.
So one of them was already approved, I think, but not for pregnant ladies.
Yeah.
Therefore. So, Dr. Alec, you talk about the effects of steroids on the preterm brains. What about the full-term brain? Like, in case we have a baby, full-term baby who needed extubation for a long time, and we are considering steroids to facilitate extubation. Are there any studies about the long-term effects of steroid on the neurodevelopment?
Not that I'm aware of, but we do have a number of sort of places that we can look for some clues to how it may affect full-term children. I think an important thing to keep in mind is that if it's just to help facilitate extubation, we generally can get away with lower doses. We've seen from adult data and pediatric data that giving doses that are in the 0.2 to 0.25 milligrams per kilogram may be sufficient to help facilitate extubation in them. In terms of how it may impact brain growth, brain development, each week that a baby ages, their brain structure is changing. It's becoming more mature, it's becoming more sulcated, and it's likely at lower risk of having adverse effects from receiving steroids. And 2 areas I think will point to that. As we give steroids to older children, in terms of more mature babies, they tend to appear to have less neurocognitive effects. And when we look to things like the chemotherapy literature, where we're giving very high doses of prednisone to infants who have leukemia and infant leukemia, we don't observe that those children go on to have the same type of brain injury and cerebral palsy that we see when we give lower doses to children who are born extremely preterm. So I think that looking at those sort of sources, it seems reasonable that a full-term baby who you're trying to promote extubation is likely to be at lower risk, but we don't have trials that can definitively say that.
Thank you.
I think the last question, because we are supposed to wind up now.
Sure. My name is Dr. Abhijit. I'm working as a neonatologist SSMC. My question to Dr. Eric, 2 practical questions. In fact, is there any role for the second cycle of DART in a failed full cycle if the baby failed to respond? And the second question, if the baby responded well within few days of starting DART, should we stop it to avoid the steroid exposure?
I think that's where the AAP would recommend that you have to use your clinical judgment. I think many clinicians would suggest that if a baby doesn't appear to be responding after a few days of therapy, it makes sense to stop it early. Whether or not you're going to achieve the same benefit if you give it shorter and the kid has responded, are they going to rebound? I don't know that we entirely know that. We've looked at giving in the 4 to 5 day range, and appears that the effect is about the same, but if it's at 2 days, it's unclear. But I don't think it's unreasonable to try to shorten a course to minimize exposure if your singular goal is to promote extubation success. Giving a second course of DART, again, I think is up to your judgment. If the child is at very high risk of having severe lung disease or other impairments due to being on a ventilator that you think you can mitigate by giving a second course of DART, perhaps if they were a responder earlier on, but now they have a new insult, an infection or neck or something, I think it's reasonable to consider and have a discussion with family about the pros and cons. But certainly I don't think there's any data out there to inform that specific question in a way that you can provide a robust assessment of the evidence.
Any minimal duration between the 2 cycles, if at all?
Sorry, say that one more time?
Any particular minimal duration between the 2 cycles of DART if we want to give the second cycle?
Oh, yeah, I don't think that there's any way to inform that question. I've certainly seen us use it with an immediate restart if the child rebounds, and that's because they're at a very high risk. And but I've not seen any data to say how long you should or shouldn't wait in between a course.
Thank you very much.
Okay, I think we should stop here. And thank you everybody for this exciting discussion and very well presentations, all the speakers as well. So we are announcing that I think we're returning back by 2:15 for the next session to start. Thank you so much.